Ever wonder if that chronic heartburn you've been dealing with could be, something more? Well, today, we're diving deep into the latest thinking on a condition called Barrett's esophagus. It's a fascinating story about how our bodies try to protect themselves and how medicine is getting smarter about staying one step ahead of a serious health risk.
All right, here's how we're going to break it all down. First, we'll get into what Barrett's actually is. Then, we'll look at how doctors find it and keep an eye on it. We're also going to cover the cutting-edge ways it's treated. And finally, we'll wrap it all up with what this means for you, the patient. Let's get into it.
So, first things first, let's get a really clear picture of what we're actually talking about when we say Barrett's esophagus.
We've all had heartburn, right? That burning feeling? But for some folks, when that acid reflux becomes chronic, what doctors call GERD, it can actually trigger a pretty amazing and important change inside your body.
Okay, think of it like this. The normal lining of your esophagus is kind of delicate, like a nice green lawn. Now, if stomach acid keeps splashing onto that lawn day after day, it's going to get damaged. So what does the body do? It gets smart. It starts paving over that damaged lawn with something tougher, like concrete. This new acid-resistant tissue, that is Barrett's esophagus. It's a defense mechanism.
And here's what that concrete actually looks like to a doctor during an endoscopy. You see that distinctive salmon-colored patch? That's the Barrett's tissue. You can really see how different it is from the normal pale pink lining around it. It's a very clear visual cue that a change has occurred.
Now, this is the reason we pay so much attention to it. Barrett's itself is not cancer. But, and this is a big but, it's the only condition we know of that can lead to a specific and very serious type of esophageal cancer. That's why we watch it so closely. The whole goal is to manage the risk and catch any trouble way before it becomes serious. Okay, so if this is a hidden change deep inside, how in the world do doctors even find it? Well, it all starts with figuring out who should even be looking.
Now, this is super important. The guidelines don't say that everyone with heartburn needs to be screened. Nope. They focus on a specific high-risk group. So if you have those chronic reflux symptoms and you have 3 or more of these risk factors you see here, things like being male, over 50, a smoker, or having a family history, that's when a one-time screening is suggested.
For decades, the gold standard for diagnosis has been an upper endoscopy. It's a procedure where a doctor uses a very thin, flexible tube with a camera on the end to get a direct look at the lining of your esophagus. They can also take tiny tissue samples called biopsies.
But this is where things get really cool. The technology is evolving fast. We're now seeing these amazing, less invasive tools. One of them is basically a little sponge packed inside a pill that you swallow. The capsule dissolves in your stomach, and as the doctor pulls the sponge back out on its string, it collects a sample of cells. It's a potential game changer for screening, and you don't even need sedation.
But just seeing that salmon-colored tissue isn't quite enough for a final diagnosis. A pathologist has to look at those biopsy samples under a microscope. They're looking for a very specific change called intestinal metaplasia, cells that look more like they belong in your intestine. And, for an extra layer of safety, if any potentially precancerous cells are found, a second expert pathologist has to review the samples to confirm.
Okay, so you have a confirmed diagnosis. What now? For the vast majority of patients, the answer isn't some aggressive treatment. It's a really careful and well-planned strategy of surveillance. And this isn't just a random checkup now and then. It's a very systematic process. It starts with a high-quality exam, and the biopsies are taken in a specific, grid-like pattern to make sure nothing is missed. And again, if anything looks off, a second expert confirms it. Based on all that info, a surveillance schedule is created that's personalized just for you.
And this quote, this really gets to the heart of the modern approach. For most people, the risk of Barrett's ever turning into cancer is actually very low. So the whole point of surveillance is to provide peace of mind and catch any potential changes super early, not to create anxiety. It's a real shift towards reassurance through watchful waiting.
This right here is one of the biggest and best updates in the new guidelines. Surveillance is no longer a one-size-fits-all deal. If you have just a short segment of Barrett's tissue and no abnormal cells, your next checkup could be 5 years away. If the segment is a bit longer, it's 3 years. This is so much more personalized and, frankly, less of a burden on patients.
So what happens if that careful surveillance does find something? What if some of those precancerous cells, a condition called dysplasia, show up? Well, this is where we see some of the most exciting and hopeful advances.
The old approach might have been to just watch and wait a little closer, even with dysplasia. Not anymore. The new standard is to be proactive. When these precancerous cells are found, the recommendation is to get in there and remove them, stopping them from ever having the chance to become cancer.
Just take a look at this comparison. It is so powerful. In the past, the main option might have been a massive surgery to remove part of the esophagus. Now we have these amazing, minimally invasive therapies done with an endoscope. And here's the kicker, the 5-year survival rates are pretty much the same, but the risks, night and day. The endoscopic route is just so much safer.
So here's how it starts. Using these incredible high-definition endoscopes, doctors can meticulously inspect the Barrett's tissue, looking for any tiny spot that looks even a little bit suspicious, like the lesion you see right there. That's their target.
And then, using highly specialized tools through that same endoscope, they can perform a procedure called endoscopic mucosal resection. They can literally shave off just that abnormal layer of tissue, leaving the healthy esophagus underneath completely untouched. It's an incredibly precise way to stop cancer dead in its tracks.
Okay, we have covered a ton of ground. So let's bring this all home and boil it down to the key takeaways that really matter for anyone on this journey.
So, what's the bottom line here? First, Barrett's is a manageable condition. Second, screening is targeted and smart, not for everyone. Third, your follow-up plan is personalized to you. And fourth, if treatment is ever needed, the options we have now are incredibly effective and minimally invasive. The most important thing is to take this knowledge and have a real, informed conversation with your doctor about what it all means for you.
And that leaves us with a really powerful thought to end on. With all these breakthroughs in finding things early and treating them so effectively, are we moving into a new era? An era where this specific type of cancer could become almost entirely preventable? The whole story of Barrett's is changing, from one of risk to one of prevention and control. Thanks for joining me.